Okay, welcome to the Davies Use Case webinar being presented by California Correctional Healthcare Services on improving influenza vaccination using patient registries. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety here at HIMSS. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support, best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievements of organizations from around the world who've utilized health information and technology to improve patient outcomes and value. The Davies Awards winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information technology-enabled care delivery. This is my pleasure to welcome our speakers for today's call. Today's webinar, Dr. John Dunlap and Michael Selby. Dr. Dunlap and Michael, I will turn the presentation over to you, and you can begin when you're ready. Thank you for joining us today.
Hello and welcome to California Correctional Healthcare Services Davies Award presentation on improving influenza vaccinations using patient registries. My name is John Dunlap. I'm the Deputy Medical Executive for the Quality Management Unit at California Correctional Healthcare Services. My co-presenter is...
Hi, I'm Michael Selby. I'm the Health Program Manager 3 over the Performance Evaluation team within the Quality Management section.
So today we're going to talk to you about our process for the influenza vaccination improvements, talk about what our problem was, design implementation to try to address that problem, how we implemented an IT solution, and then what value we got out of that. So what was our problem? Well, basically, we wanted to know if we could improve vaccination rates and reduce the healthcare impacts of influenza in the California prison system. The challenges that we face is that we are overcrowded, so basically we're at 132% of capacity. We have significant morbidity amongst our population, so 13% of our population is identified as high risk. More than 50% have chronic conditions identified. And we are a very migratory population, meaning that 11,000 transfers occur every month for the inmate population between the institutions. The other piece that is really important to understand is that our prison system is not a solitary system. We actually integrate quite significantly with the free community. And that's really what this diagram is trying to demonstrate, that not only do inmates move in and out of the prison system from society, but we also have prison staff and visitors that come in and out every single day. And we have other staff and employees that come in and out. So you see that this is really a busy slide, but basically what it's saying is that flu can spread pretty easily and dramatically throughout our system. Where do we start? So our 2016-2017 influenza vaccine rates were basically just slightly over 3/4 of our population actually were offered it, and only 38% actually received this. We didn't have a really good way of tracking our patients, and what we would try to do in this effort was we would do statewide mass vaccination days where the institutions across the state would shut down for a day, and we'd try to basically corral 125,000 patients through to get vaccinations administered, or at least offered, and then they could refuse that if they wanted. The problem with this is that the mass vaccinations would shut down all the other programs, education, vocational programs, visiting, that kind of stuff, that was really disruptive to all of the other programs and mechanisms within the prison system. And, prior to this, our solution was that this was a paper-based tracking and reporting, so lots of time was spent doing chart audits, and it's consumed a lot of clinical people's time. And healthcare staff had to they had to themselves remember to look up to see if a patient was offered or received. And when every time a patient moves, the nurses would have to go back and see whether it was offered or not. So again, 11,000 moves every month throughout the flu season. There was a lot of inefficiencies in the administrative processes. So what did we hope to accomplish with this? So clinically, we wanted to increase our offerings to virtually offer the vaccination to every inmate. And then we wanted to see an improvement in the actual administration of the influenza vaccination. Beyond that, we were hoping that we would see reduction in preventability of morbidity and mortality associated with influenza. And we wanted to do this through basically improving the process administratively so that we could track patients efficiently, effectively, and provide timely, actionable information to the end users, healthcare users, and provide near real-time performance reports for management. So design and implementation. Commercial off-the-shelf products, really there is no sort of health tool out there that we could find that was looking at tracking influenza vaccination specifically. And we were in the midst of deploying a full electronic health record. But at the time flu season started in 2016, we were not fully implemented. And the encounter strategy that we deployed for our 35 institutions made it very difficult for us to reliably panel patients within the electronic health record system. And our local IT shop was not resourced or funded to build this application. Their attention was on the deployment of the electronic health record and also developing the electronic dental record system that is currently being deployed now. So what we opted to do was to leverage our existing resources. We had in-house talent to build the solution, both analytic technical building and as well as clinical SMEs. We partnered with both our public health branch and nursing services to inform this project. We'll talk about that a little bit more later. But we also had a structured data warehouse that really is what we leveraged to make these tools happen. So we developed our IT workflow, which, in simplistic terms was, we wanted to leverage the information that clinicians put into the front end through data entry. So if a patient recorded, if a patient received it, that would be captured through the medication administration and or our pharmacy data. And then we would track refusals if those were entered in through the health record system. The data warehouse would then extract that information, and it would refresh this every 24 hours, and that information would feed up through to a patient registry that clinicians would look at and could be updated on demand or pulled up on demand, and to identify who needed influenza vaccination offering and or who had refused, so they could revisit those patients to try to get them to change their mind and receive the vaccination. Also, that information would then be updated to show real-time performance, or I should say near real-time performance, basically lagged by about a few hours to a day. So we involved users in a design of our workflow because we had an established process that was largely paper-based, and then we had several institutions that had implemented a health record, electronic health record. There was not a lot of time spent to really think about how we were going to start doing vaccinations. There were some people who were advocating for really pushing to continue with the mass vaccination approach, and there were others that really wanted to try to change that model to just being everyday business through our primary care teams, that they would be able to call in people to provide the vaccination without having to disrupt a lot of other programs and processes within the prison. That latter option is what the public health branch and nursing services advocated for, but they also allowed for individual institutions to continue to do max vaccinations if they wanted. As we move forward into this year, again, there is a stronger encouragement to move away from mass vaccination and just making this part of everyday primary care. But going back to that, our users were really helpful in defining the workflow for our programmers, and also to train our end users on how to enter information into the system. We'll show that in more detail a little later. We also had them identify data elements used on the front end, so our programmers knew where to look for stuff in the back end tables. They also developed the rules for the IT programmers to use. So, for instance, our public health branch wanted us to incorporate the Prevnar as an additional factor to be considered to be given for high-risk individuals. And then also we use our end users to basically validate the output of the program. So making sure that the expectations of the end user, the business rules, were met by the program. So again, here what we're showing is the clinical SMEs. So again, our nurses and public health people helped identify the workflow on the front end on how to properly enter this into the front end of the electronic health record system. They also helped identify the specific elements that would be needed from the back end to pull. And again, we made sure that what you see here on this screen is on the left-hand side is the tool that was developed, the Influenza Vaccination Registry, and correlating that to what's on here on the right-hand side, which is the element from the front end of the electronic health record. So making sure that the information was matching correctly. So the secret to our success repeatedly has been the partnership of our clinical SMEs with our programmers, having them co-located and working closely together in a back and forth iterative process has been really one of our secrets to our repeated success in developing our healthcare IT tools. All right, I'm going to hand it over to Mike, who's going to go into a little bit more on how we utilize the IT.
Thank you, Dr. Dunlap. So once the clinical guidelines around flu vaccination were in place and we had identified the data points used to map to the applicable values between the front-end applications and the back-end database tables, we were able to build the flu registry. So that is what you see on the screen now. So this is a SQL Server Reporting Services, or SSRS report, which pulls data from our back-end SQL Server data warehouse. Now, SQL Server Reporting Services is a Microsoft commercial off-the-shelf product, so anyone can get and use it. It integrates very well with a SQL Server backend database, but can also be used to connect to a number of different data sources. So depending on what your institution or organization uses, you can likely connect to whatever your data sources are through SQL Server Reporting Services or another product like it. So this is an automated report people are able to access through a web-based interface. So essentially they can go locate this report through a web browser. The top of the report has a number of filter options that they can select and then see the information down below. So in this particular report, each patient gets one row on the report, and we display various information about that patient and their flu vaccination status across the row. So on the left-hand side, we have basic patient identification, housing, and ethnicity information. And then on the right-hand side, we show the status of whether or not they have been offered the flu vaccine and if they accepted it or refused it. So the basic functionality of this and our other patient condition registries includes automatically detecting a user's assigned institution and showing the patients at their particular institution by default. They can also view patients at any other prison in the state, or they can see all patients across the state in one report. And then on the other end of the spectrum, we also give providers the ability to see just the specific patients on their care team or patient panel. As with our other patient registries, this report also includes the ability to sort on any of the columns in the report. So clicking on any of the column headers where you see the small arrows will sort by that particular column. So you can see certain data elements or certain groups of patients all together. We also include filters on this report. So we can include filters for age, either under 65 or 65 and older, and by ethnicity. Now, at one time, we tracked performance with respect to flu vaccination across our organization on what we call our healthcare services dashboard. Our healthcare services dashboard is our internal and also public-facing performance monitoring and surveillance application. But a few years ago, we took off flu vaccination reporting because it was just a seasonal thing. So when we built this tool, we built performance reporting directly into the report. So the top section of the report shows how many patients are being included on the report based on the filters chosen. You see in this particular case, we've actually chosen everyone across the state, so there's 122,000 patients in this view of the report. And then we show that what the status of each patient's flu vaccine is. So completed, refused, contraindicated, or not offered. And then we display the patient count and percentage of patients in each of those four categories at the top of the report. So prisons can monitor their progress with offering the flu vaccine to all patients. They can also easily filter the report down to those who haven't been offered the vaccine, and then that list can be exported into Excel or PDF or printed to get that information to the staff who will need it. And similarly, this report, to facilitate that, has a quote-unquote Excel-friendly version where we've essentially stripped out the header and footer information of the report, which makes it easy to sort and filter and do analysis of the data in Excel. On the Excel-friendly version, we've also included additional columns, such as whether the flu vaccine has been ordered for a given patient, and information around patient disabilities. And finally, like our other registries, clicking on the patient's CDC number will bring up the patient summary report. This is the Excel-friendly version. And like our other registries, clicking on any of the patient's identifier numbers will bring up another report we have, which is called the patient summary report, which is basically a one-page summary of all the healthcare factors related to that patient, to link it to our other tools. All right, what changed with the introduction of the registry? So prior to the introduction of the flu registry, As Dr. Dunlap mentioned, prisons across the state would shut down their normal operations for a day and do a mass effort to get all inmates vaccinated on the same day. As he's mentioned, this was a big disruption to operations, and paper or Excel logs were created to track who had received the vaccine and who had not. This tracking and the overhead of work involved took a lot of staff time. If anyone was missed, chart audits would need to be done later to find the patients who had missed the mass screening for whatever reason. So now with the creation of the flu registry, all that goes away. So providers could see who had and who had not been offered the flu vaccine registry, or who had been offered the flu vaccine registry, so they could offer it to patients within the normal course of their care. They also no longer needed to track patients, manually track each patient's status on the manual log. They could just do their normal documentation within either the new Cerner EMR or within our legacy patient health information portal. And data from both systems would be fed into our SQL Server data warehouse and would then be used to populate the data on the registry. We also encouraged institutions to add this to their topics of discussion at what we call population management working sessions, which are meetings held twice a month. These are meetings with 1 or 2 clinical care teams, including the medical provider, registered nurse, LVN, and their executive. And at those meetings, staff review the flu registry and the other registries produced by our section to find patients who hadn't been offered the flu vaccine yet this season, and then they could schedule them and get them in to be offered the flu vaccine. We also encourage staff to address patients without a flu vaccine at their morning huddles, which is a time in which they discuss their patient panel and anything that needs to be done to particular patients. So there's a little more information about the population management working sessions. So as mentioned, it's time for the care team to just come together to discuss intervention strategies with hard-to-reach patients, find and order diagnostics or medications as appropriate, and just work on essentially the coordination between the members of the care team. All right, how did we build this tool? So when we built the flu registry, we had a fairly robust infrastructure already in place in terms of a number of other condition-specific registries and other tools that were all pulling data from a centralized SQL Server data warehouse and displaying the information in a web portal running SQL Server reporting services. So these other patient registries included registries for patients with diabetes, asthma, HCV, HIV, end-stage liver disease, or a variety of mental health conditions. And these all had a consistent look and feel that our staff were used to using. So for this project, we definitely wanted to leverage that existing infrastructure in terms of the back-end SQL Server and the front-end SSRS reporting server, which staff were already used to using for all of our other tools and our healthcare services dashboard. The one tricky thing as we were building this was that, as Dr. Dunlap mentioned, at the time we were releasing this, we were also rolling out a new electronic health record system. But at that time, only some of our institutions were on the new electronic health record system, while others were using our legacy, essentially homegrown, rudimentary EMR. And so we had to combine both those two disparate data systems into one centralized data warehouse. Now, over time, this new electronic health record system has become our biggest and most important data source, but at that time we developed this tool, it wasn't used everywhere. And so having that centralized data warehouse was what enabled us to make this report that's able to handle the situation where if a patient transfers from an institution with the new EMR to a prison without it, the data on our flu registry, as well as all of our other registries, would stay up to date from either system. So there was no need to do any double entry in both systems. We were able to pull from both systems simultaneously and display information from both systems to all end users. Now, as with all of our other tools we build, we work very closely with our clinical SMEs, including public health staff, to design the front-end view of the flu registry. And we do this to ensure that our tools are aligned with the clinical recommendations and that the information we display makes sense to the end users. Now again, as Dr. Dunlap has mentioned, the existence of this centralized SQL server containing all the relevant healthcare and custody information that can be accessed and queried by analytical staff like me and my team, sitting next to clinical SMEs like Dr. Dunlap, is how all this happens effectively. Together, we're able to develop tools that provide actionable information to drive performance improvement and make it easy to do the right thing. So let's talk a little bit more about what our data warehouse infrastructure looks like. So this is a high-level diagram of how it works. So on the left-hand side, we have a number of data sources feeding data in to the SQL server. So we've got our electronic records system, health record system. We have SOMS, our custody information. We have a number of legacy and other applications feeding data in. And then we have SharePoint lists. We have Excel files that also get loaded into the system. And so we take all this raw data, and then we have what's called an ETL, or extract, transform, load process, which then takes all this raw data and converts it into a more structured, usable, consistent format. Once we have that data in that more structured, consistent format in the data warehouse, we're able to do a lot of things with it. So we're able to do ad hoc analyses or data mining. Those usually start from questions our executives have about how a new project or program is going. So we can see essentially the progress we've made or issues that that project is having. And then the other big use case is for reporting. So as we mentioned before, we built the flu registry. It's one of our reports. But we've got a number of other existing reports, a number of other patient registries or patient profile views, and then our dashboard, which is our surveillance monitoring and performance improvements tool. So that's at a high level how our data warehouse operates. We get these automated data feeds into one location. We transform the information to make it more usable for our staff, and then we use that information to produce reports for end users. All right, so how did we get staff to use this tool and follow the new process? Since this involved a large process change at our institutions in terms of going from one-day mass vaccination efforts to a more continuous vaccination effort, executive forums at all levels of the organization were used to communicate this change. Public health and medical executives took the lead on the messaging as their staff were impacted the most. We also sent out an organizational memorandum announcing the change, sharing the why, and messaging expectations about who would use the tools and how. Existing policies and procedures also had to be refined to ensure sustainability of this new process. And then both as we were developing the tool and the process and afterwards, focus groups were held with headquarters, regional, and institution staff to provide feedback loops on the tools and the processes. These staff also helped with initial and ongoing data validation efforts to ensure that our tools, in this case the flu registry, are as accurate as they can be. Now, in an effort to make our tools as easy to use as possible, decision support documents, including user guides and training materials, were also produced for the reports, and multiple webinars were held. These webinars were led by public health staff with support from the quality management staff who built the report in order to increase awareness of and understanding of the new process and the tools at their disposal. And then finally, at the end of last flu season, a post-implementation status report was created to highlight the progress that was made based upon initial implementation of the flu registry and the vaccination process. All right, and now I'll pass it back to Dr. Dunlap to let you know how it all turned out.
All right. Thank you, Michael. So, what did we achieve? This graph shows the usage report. I'm sorry, the table on the left-hand side shows the usage report month to month during last flu season. So really, we didn't get this tool built until September, so we were a little late in the flu season. But you can see on the right-hand side in the graph that we had tremendous usage and offering of the vaccination that corresponded with usage. So you see that the usage and the offering and acceptance were very large in the first few months, and then we see a tapering down of usage and the offerings later into the flu season, which is what we would expect to see. In terms of the improvements, we had a 19% increase in the offering rate, so we achieved a greater than 95% offering, which was fantastic. And we suspect that probably the 4% that weren't offered were new arrivals into our system towards the latter part of the flu season. So while we do offer the flu vaccination throughout the flu season, usually by the springtime, people aren't really thinking about flu anymore, at least not here in California. And we also saw that there was an increase in the vaccination rate by 8%. So we went from 38% to 46%. So when comparing ourselves to the outside world, our HEDIS comparisons roughly for 2016 looked like 45% received it for the 18 to 64-year-old population. So we were right on par with that last flu season. And then we did just slightly better in terms of our 65-year-old and plus population, 74% for us versus 72% for the 2016 HEDIS score. So did this translate to cost savings or health improvements? What this table shows is the flu seasons going back to 2012, 2013, and really what you see is actually our ER costs went up in the early seasons, but we did see a decline between 16 and 17. Is this significant? No. I think that this is probably more likely due to variation within the flu seasons, but we did want to just show that this was something we looked at. And while it doesn't look like we saved money in terms of emergency rooms and emergency room costs or hospitalization costs, overall, that we think that there is still benefit. And that comes in the way of our cost savings from administrative processes. So here what we're showing is that the estimated costs to develop the tool in terms of clinical SME time and the staff time from the analysts was a one-time cost of $75,000, and we are estimating our maintenance costs about $20,000 per year. But then when we compare to the costs that we believe are being saved in the nursing time reviewing charts, we did just a swag calculation here of that we thought a diligent nurse could be doing 20 charts per hour to review, and we had 122,000 inmates, so that's roughly translating to 6,100 nursing hours, and at $65 an hour, we're looking at just under $400,000 a year. So again, minus the costs to develop the tool, our first year's savings, we are looking at $300,000, but subsequent years are looking to be about $375,000 per year. So, just in review, improved care and reduced costs. We did achieve our goal of increased offerings and vaccination rates. Did we reduce preventative morbidity, mortality? Jury's still out on that. I think maybe if we can improve vaccination rates and we can look at more data over a longer period of time, we may in fact see this translate. On the administrative side, we achieved all the things that we wanted to. Again, an efficient and effective way to track the patients throughout their incarceration, to provide the timely and actionable information to the line staff who do the work, and then performance reports for our managers. So user feedback. One of the benefits of our performance evaluation team and the quality management unit as a whole is we have a very strong customer service focus, and we set up communications through our organization. So here what you're seeing on the left-hand side is our intranet site. This is not freely accessible to the outside world. And you see here is a banner talking about sort of the campaign and applauding our audience or our end users on that we achieved our highest vaccination rates yet over the times that we've been measuring. And we also put out a little report showing what we did in terms of performance. We also maintain an inbox, so people can email us and allow us to identify problems that come in. So, when there's user enter, or when you have people entering information into the system, inevitably there's going to be a data error entry that goes in. So they can reach out to us to say, hey, I entered this as a completed influenza vaccination when in fact this wasn't completed. Can you invalidate that entry? So we can go in and reverse things on our end if need be, though we try to instruct them on how to correct it on the front end, because we don't want to be manipulating the data in the data warehouse. All right, so lessons learned. Our population management sort of philosophy is essential, I think, for primary care. So we create tools that are looking at the population. We want to remind the primary care team members, the nurse, the doctor, all those that are involved in the care, that while you're seeing a patient in the clinic, there are hundreds or thousands more that aren't being seen. And if they don't come to see the nurse or doctor, there are still primary care services that need to be rendered to those people. So the population health tools that we provide are a very nice complement to the decision support that's built into a front end of an electronic health record system. The other thing is, throughout all of our experiences, is that the healthcare data that comes in from a variety of sources, whether you have a full electronic health record system or you just have sort of individual data sets, whether it be lab, pharmacy, diagnostic codes, that information is invaluable to your healthcare organization and should be leveraged just like any other asset of that organization. You can save money by doing this. The anticipated resources should be thought beyond your design, development, and deployment. So this is a lesson that we're still sort of feeling the pain from, in that in the early years, we built a whole lot of tools for a lot of different customers, and not thinking that forward thinking in that these tools would need to be sort of regularly maintained. And so while our staff have sort of reverted to more of a maintenance and operations, our customers are still wanting us to produce new reports and measures. And so it's a delicate balance for us, but our production certainly has slowed down as we have to spend more time with maintaining the existing tools. Change management is key for successful adoption. So while we can build these tools for end users, we find that it really takes the whole organization to make it successful. So you need leadership to help communicate this. And really when you have peer-to-peer presenters, so people, nurses presenting to nurses, doctors presenting to doctors, that always has been a very successful strategy for us in terms of getting people to accept behavior change. If it's coming from somebody that's like them and they can articulate that it's not a big change and explaining why it's valuable to have the change, we see that that's better accepted. Is it a perfect solution? No, it's part of a solution. I think also specific to this initiative, we probably should have thought more about primary care specific metrics as opposed to community hospitalizations or ED. So we thought maybe retrospectively we could have looked at primary care visits for influenza-like illnesses, or maybe a specific for our correctional encounters is a reduction in these confined to quarters that are put into place by our public health nurses at the institutions when patients present with influenza-like illnesses to help reduce the spread of influenza. And then last but not least, which is what I said earlier, is I think the secret sauce to our repeated success is the co-location of your informatics programmers with your informatic clinical SMEs, and to really produce high quality tools that will be easily accepted by the end users in a much more efficient timeline. Thank you again for your attention, and we hope that this was useful to you all. Thank you.
Okay, we would like to thank our speakers from the California Correctional Health Care Services for joining us today and speaking on their Davies use case. We would like to remind our listeners where to go find this Davies use case and other important information on how to apply for Davies. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies. That is hims.org/Davies. Once again, we would like to thank our speakers today and thank you for listening.